Welcome everyone. This video is on bacterial corneal ulcer and it is made mainly for the purpose of third year MBBS students, their theory exams, preparation for NEET PG or next. To begin with, corneal ulcer. What is corneal ulcer? Corneal ulcer is defined as any discontinuation in the normal epithelial surface of cornea associated with necrosis of surrounding corneal tissue. So the cornea has 6 layers. The uppermost layer is the epithelium. Then we have the Bowman's layer, and then we have the biggest layer, stroma, and then there's pre-Descemet's layer and Descemet's layer, and then the endothelium. So any defect in the epithelium which affects its continuity along with necrosis of the surrounding corneal tissue, that means the Bowman's membrane and the stroma, this is known as a corneal ulcer. Now, when the cause of this corneal ulcer is a bacteria, it becomes bacterial corneal ulcer. So, moving on to the etiology, there are two main factors that contribute to the development of bacterial corneal ulcer. So, first one is there should be a damage to the corneal epithelium, and then this damaged corneal epithelium is invaded by the causative organisms. In this case, it is the bacteria. So how does damage occur to the corneal epithelium? So corneal epithelium can be damaged by corneal aberration, epithelial drying, necrosis of epithelium, disformation of epithelial cells, epithelial damage due to trophic changes. Now corneal aberrations, how can corneal aberrations come? Corneal aberrations can occur due to small foreign body which gets impacted on the cornea. It can be due to misdirected cilia, concussions or trivial trauma due to contact lens wearing. And epithelial drying. Epithelial drying can be associated with a dryness of eyes, or xerosis. It can also be associated with exposure keratitis. And what is exposure keratitis and xerosis will be explained in upcoming videos. Necrosis of epithelium. Now, a necrosis of epithelium can be seen in keratomalacia. That also will be explained later. Disformation of epithelial cells. Disformation of epithelial cells can occur as a result of corneal edema, as we see in bullous keratopathy. Then, epithelial damage due to trophic changes. There can be neuroparalytic keratitis, that is a type of trophic change, and all this will cause epithelial damage. Now, there are some organisms which do not need this damage in the corneal epithelium. They can invade the intact corneal epithelium. These include Neisseria gonorrhoeae, Neisseria meningitidis, Corynebacterium diphtheriae, Haemophilus aegyptius, Listeria species. Now, the other causative organisms, they include all gram-positive organisms and gram-negative organisms, both cocci and bacilli. However, the most common organism in general is Staphylococcus, and the most common organism in contact lens wearers is Pseudomonas. Now, how is this infection, these causative organisms reaching the epithelial defect? So they can arise from exogenous sources, okay, or like they can come from the conjunctival sac or the lacrimal sac itself, because they may be infected and they may be waiting for some defect in the cornea so that they can come and invade over there. So when that arises, the organism will come from there and easily it will come onto the cornea. Similarly, any infected foreign bodies which lands on the cornea, or infected vegetative matter, or contaminated water, and also it can be airborne. So that is it about etiology. Now pathogenesis. Now pathogenesis can be divided into, it can be divided into three types. So pathology of localized corneal ulcer, the pathology of perforated corneal ulcer, and the pathology of a sloughing corneal ulcer and the formation of anterior staphyloma. So the pathology of localized corneal ulcer is very definitive. Like there are 4 stages, and that ulcer passes through all these 4 stages and it ends by healing. Okay, so now to explain that, once the organism has invaded the epithelium, now the organism has reached the epithelium, the ulcer has started to develop. The first stage is Stage of progressive infiltration. So the defect containing the organism is infiltrated by polymorphonuclear cells and lymphocytes from circulation and also from stroma if it is involved. Obviously, whenever there is inflammation, this happens. Like the polymorphonuclear cells and lymphocytes will come and they will surround that area. They will go into the area. They will try to fight with the organisms there. Then the stage of active ulceration. This is characterized by necrosis and sloughing of the epithelium, the Bowman's membrane and the involved stroma. And the walls of the active ulcer will project outward. This is due to imbibition of fluid by the stroma. Okay, so stroma gets edematous and it pushes the walls of the ulcer forward. During this stage, there is also the formation of purulent exudates inside the cornea, and there can also be, it's possible that in this stage there is formation of hypopyon, desmetocele, and there can be corneal perforation. Now, what these things are will be explained, or I can just tell now also. Hypopyon, it is due to the exudation into the anterior chamber. Okay, so when this purulent exudate is formed, it can exudate into the anterior chamber also. This happens like when the invading organism, it produces some toxins. So these toxins can be taken up by the iris and the ciliary body, and it can lead to iridocyclitis, that is the inflammation of the iris and the ciliary body. So when this happens, there is inflammation over there and there is exudation of fluid over there. And this fluid will easily accumulate in the anterior chamber, actually in the lowermost portion of the anterior chamber. So it can be seen very clearly like this pus being collected in the anterior chamber beneath. It collects below because of gravity, obviously. Then there can be possible formation of desmetocele. So how does desmetocele form? That is like when the organism is very virulent, it perforates. It goes to the epithelium, Bowman's membrane, stroma completely, and it reaches the Descemet's membrane. And in the Descemet's membrane, what happens is that by that time the cornea becomes very thin, right? The stroma makes up for 90% of the cornea's thickness. So when the stroma is gone itself, it becomes very thin. So it becomes very hard for the cornea to hold back the intraocular pressure. So obviously in that small area where that perforation has come, the Descemet's membrane will bulge out, and that is known as desmetocele. And it's very easy for this desmetocele to burst or rupture, and that would lead to corneal perforation. Okay, and all this happens when the organism is very virulent. Next is the stage of regression. Stage of regression is induced by the host defense mechanisms, and the treatment which the doctor gives, that also will augment this host defense. Okay. Then so here what happens is that there are leukocytes surrounding the ulcer, right? So they will phagocytose the offending organism and the necrotic cellular debris. And this is also accompanied by vascularization that will increase the humoral and cellular response. Obviously, when there is vascularization, all antibodies and all these immune cells, they are easily brought to the site of ulcer. So it will augment it. It will increase the regression. Now next is the stage of cicatrization. So once the all this debris and everything is cleared off, the healing will start, and this is by formation of a new epithelial layer. However, we know that if Bowman's membrane is damaged, it cannot regenerate. So there will be fibrosis. So what happens is epithelium layer is formed, but beneath that there will be fibrosis. And because of this, so what happens when there is fibrosis? When there is fibrosis means scarring. If fibrosis is there, there will be scarring. So fibrosis, how it happens, it is done with the help of two cells, corneal fibroblast obviously, and endothelial cells of the new vessels. So I said vascularization is happening. So endothelial cells will be there. So those cells are also contributing to this fibrosis. Now this degree of scarring. So fibrosis will be there, so scarring is there. So we can classify this degree of scarring. If only the epithelium is involved, then there will not be any opacity. In the sense, there won't be scarring. Then if Bowman's membrane and superficial stroma is involved, there is the formation of a scar known as nebula. If Bowman's membrane and 1/3 of stroma is involved, there is a formation of macula, which is slightly more opaque than nebula. Then Bowman's membrane plus more than 1/3 of stroma is involved, then there is leucoma, which is a big scar. It impairs vision, like substantially it impairs vision. So this is just the image of all these corneal opacities, just to make you understand. Macula is very small, as you can see, and leucoma is quite large, so it will interfere with vision. And you can see this one is completely on the pupil, so it will be very difficult for the person to see. Then leucoma with severe vascularization. Usually you don't see any vessels on the cornea, but you can see here it's completely like white. See, the entire cornea has become white, in the sense there is scarring, and then it is vascularized also. Now this is the normal pathology: stage of progressive infiltration, stage of active ulceration, stage of regression, and stage of cicatrization. This stages you should know, because they'll ask this. Then pathology of perforated corneal ulcer, and then pathology of sloughing corneal ulcer and formation of anterior staphyloma. So the pathology of lock-like corneal ulcer, that is the standard one, that you should know. Any corneal ulcer will undergo all those things. Now, if perforation happens, I already explained how the perforation happens. The ulcer will progress through the Descemet's membrane, then there is a formation of descemetocele. Then if a patient exerts, like if he coughs or sneezes, or if he strains, like while passing stools and all, if he strains, then there is increase in intraocular pressure. This will lead to perforation, then aqueous humor will escape, intraocular pressure will fall, and iris and lens will move forward. There is subluxation of the lens and iris prolapse. So if perforation is small and in front of iris, then there is plugging of that site by the iris, and then there is healing by cicatrization. Then pathology of sloughing corneal ulcer and formation of anterior staphyloma. If the organism is very virulent, or the immunity of the person is very low, or if the immunity of the person is very low, then the whole cornea will slough, and there is prolapse of the iris, and there will be formation of a lot of exudates which will block the pupil, and this exudates and this iris, they will form something known as pseudocornea. So what happens is that this exudates will rearrange themselves, and they will form a fibrous layer over which the epithelium will grow. And this is along with this iris, they will bulge forward, because they cannot withstand the intraocular pressure. They are too fragile. They are not as strong as our healthy cornea. So, and this bulging forward, this whole thing is known as anterior staphyloma. Next is the clinical features. So there is symptoms and signs. Symptoms is what the patient will tell you. Signs is what you will elicit as a doctor. Symptoms include pain and foreign body sensation, watering from eyes, photophobia, blurred vision, redness of eye. Now what you will see is that there will be swelling of eyelids, there will be blepharospasm, there will be conjunctival chemosis and hyperemia. Conjunctival chemosis is nothing but edema of the conjunctiva, and hyperemia, you all know what it is. And then there is ciliary congestion around the cornea, and then there is corneal ulcer. So corneal ulcer, most of the time it is yellowish white area of ulcer. There will be stromal edema, the margins will be swollen, and the floor will contain necrotic debris. So as you can see, if it is a pseudomonas infection, you will see greenish exudates. Okay, so that you can look at the corneal ulcer and sometimes differentiate what would be the causative organism. Okay. Next is anterior chamber. Anterior chamber, like I said, it may or may not show hypopyoid. Then iris may be muddy in color because it's not healthy. There is inflammation. Pupil will be small. Intraocular pressure will be raised due to inflammatory glaucoma. I will be explaining that. Toxic iridocyclitis. So now complications. There are 5 complications, and this is important. They can ask you what are the complications of bacterial corneal ulcer. So you should know this. Toxic iridocyclitis. So what happens is, like I said, the organism may produce some toxins, and they will be absorbed into the anterior chamber, and then that is taken up by the iris and the ciliary body, and they will undergo inflammation, iridocyclitis. Then there is secondary glaucoma. Secondary glaucoma, what happens is that there's a lot of these fibrinous exudate. So they will go and block the angle of the anterior chamber, increase the intraocular pressure, and this will lead to secondary glaucoma or inflammatory glaucoma. Next is desmetocele. So desmetocele also I have already explained. Then perforation of corneal ulcer. This also I have already explained. We have already seen this. So what happens is, like, once it perforates, the pain will suddenly decrease and the patient will say that I felt some hot fluid coming out of my eyes and suddenly all the pain went, and only he or she will tell you. So there is something called as sequelae of corneal ulcer. This you should know because they might ask this as a 5-mark question alone. That includes prolapse of the iris. The iris will come forward. Anterior dislocation of the lens, that also, and lens will come forward. Then anterior capsule cataract. This is when the lens will come and fall onto the pupillary area, like where the perforation has taken place. Then corneal fistula can take place, where the continuously aqueous humor is coming out. Then there can be purulent uveitis, endophthalmitis, or even panophthalmitis due to intraocular infection. Like the infection is getting disseminated, the entire eyeball is getting infected, and it can lead to panophthalmitis, which is a very serious condition. Then intraocular hemorrhage, which can be due to vitreous hemorrhage or due to expulsive choroidal hemorrhage. And this will occur in some patients due to sudden lowering of intraocular pressure. Next is corneal scarring. So corneal scarring also I already explained. This will lead to permanent visual impairment, astigmatism to be precise. Patient will have astigmatism. Now treatment. In treatment there is, so the treatment is different for an uncomplicated corneal ulcer and for a corneal ulcer which is going to perforate. Okay, like you can see, desmetocele is formed, it's going to perforate like that. So for uncomplicated corneal ulcer, the thing is that you should try to prevent this from happening. So this is what they'll mostly ask you, like how do you treat an uncomplicated corneal ulcer? That is what is important as an MBBS student. So there is definitive treatment, there is adjunctive therapy, and then there is physical and general measures. So in definitive treatment, you can give topical antibiotics to cover both gram-positive and gram-negative organisms, because at least at first when the patient comes to you, you don't know what organism is, which organism is causing this, and sending to microbiology will take a lot of time. It's very important that you start imperative therapy, like you just start with both antibiotics that cover both gram-positive and gram-negative organisms. So what you can give is, you can give any of the two following drugs, like you can give fortified cefazolin along with fortified tobramycin, or you can give fortified vancomycin along with fluoroquinolone eye drops like getafloxacin, moxifloxacin, ciprofloxacin eye drops. Okay. Then systemic antibiotics are also given, but this is when the case is very fulminant, okay, very serious. There you can give a cephalosporin along with an aminoglycoside, or you can just give oral ciprofloxacin. Now adjunctive therapy, this is also asked. They ask you, why are you giving cycloplegics in uncomplicated corneal ulcer? What is the benefit of giving atropine? So one person adjunctive therapy, actually there are three things that we give. One is cycloplegics, then there is systemic analgesics and anti-inflammatory drugs, and then there is vitamins. So first is cycloplegics, which is like a separate 5-mark question. They'll ask you why you're giving cycloplegics. You give atropine because it will help reduce the pain from ciliary spasm, and also it prevents the formation of posterior synechiae. It increases the blood supply to anterior uvea, and so brings more antibodies into the aqueous humor. So obviously when there is more blood supply to the uvea, it will bring more antibodies through the blood and into the aqueous humor, which will help fight the infection, right? Then there is reduced exudation by decreasing hyperemia and vascular permeability. Okay, so there are 4 things which you should know. This is like, you should know, like they'll ask you for whys and all, it should come like that from your answer should come like that. there is reduction in pain due to ciliary spasm, prevention of formation of posterior synechiae, increased blood supply to anterior uvea, hence helps fight infection in the aqueous humor, then reduces exudation by decreasing hyperemia and vascular permeability. 4 things, very important. Then hometropin is another. Instead of atropine, you can give hometropin 2%. Systemic analgesics and anti-inflammatory drugs like paracetamol, ibuprofen for pain, edema. Then vitamins to help healing, A, B, C, all you can give. Then physical and general measures, you can give hot fermentation, it will give some relief, like it will help with the pain. Dark goggles to combat photophobia, rest, good diet, fresh air, it will add to the treatment. Now impending perforation, like the ulcer is like just waiting to get perforated. So what will you tell the patient? You tell the patient, don't exert yourself, don't strain. Then you give pressure bands for external support, and then the intraocular pressure is increased, right? There is this fibrinous, there is inflammatory glaucoma. So you give in glaucoma drugs, you give acetazolamide, you give mannitol, you give glycerin, you give timolol. Then there is tissue adhesive glue. This will help, like you can add, you can for time being you can put that, and you can prevent the perforation from happening. Or the item that we use is cyanoacrylate. Then bandage soft contact lens. Then you can give conjunctival flap. You can take a little bit of conjunctiva and put it over it to avoid the perforation. Then amniotic membrane transplantation. Then penetrating therapeutic keratoplasty. There is something known as therapeutic keratoplasty. Like when the cornea is going to perforate, if you are able to get a cornea matching, then you can put that. That's it. Thank you.